My dear students, Dr. Ashfaq over here, and as you are well aware, I have authored books for NEET PG, NEET DM, NEET MCH, as well as some of the books for USMLE examinations, MRCP examinations, and my lectures would be intended to get you right on the top there for your next examinations, DM examinations, MCH examinations, MRCS, MRCP, USMLE examinations. I hope my videos will benefit you a lot. I will be presenting my things in a very easy, simple and palatable form for you. Wish you good luck for your exams. Thanks a lot. My dear students, today I would be taking up a topic very important and the most high yield points about this topic. That would be the embryology of the tongue and the embryological defects of the tongue in detail with all high yield points. Firstly, this tongue should not be used excessively. That's the most important point, harshly or rudely. So now going on to topic, main topic. As far as the embryology of the tongue is concerned, we have to remember that tongue develops in relation to the pharyngeal arches, and our knowledge of pharyngeal arches suggests that we are already aware of the 5 pharyngeal arches. Tongue predominantly develops in relation to 1, 2, 3 and 4th pharyngeal arch. Now, during the 4th week of intrauterine life, we have got the appearance of 2 swellings, one on the right side and one on the left side in relation to the pharyngeal arch number 1. And these swellings are given the name as lingual swellings. Another swelling appears in between and just below the lingual swellings, and that is given the name as tuberculum impar. Now, our knowledge of anatomy of tongue, we know tongue is divided into anterior 2/3 and posterior 1/3. The anterior 2/3 of the tongue would be developing in relation to the first pharyngeal arch from the lingual swellings and tuberculum impar. After that, we have got the pharyngeal arches 3rd and 4th. The posterior 1/3 of the tongue would be developing from these arches predominantly, and there is the appearance of an eminence which we give the name as hypobronchial eminence, which will be divided into 2 parts, the cranial part and the caudal part, and the cranial part will be given the name as copula of His. So the posterior 1/3 of the tongue would be developing from the hypobronchial eminence in relation to the arches 3 and 4. Now, the whole embryogenesis dictates the nerve supply of the tongue. Anatomically also, anterior 2/3 is slightly different from the posterior 1/3. So once we ask a student the question, what is the nerve supply of the tongue? We know anterior 2/3 develops in relation to the first and the second arch. The nerve of the first arch is the mandibular nerve. The lingual branch of the mandibular nerve would be general sensation to the anterior 2/3 of the tongue, and a branch from the facial nerve, the chorda tympani, would be special sensory to the anterior 2/3. The posterior 1/3 develops in relation to the 3rd arch predominantly, and the nerve of the 3rd arch is glossopharyngeal. So glossopharyngeal nerve is both general sensory as well as special sensory to the posterior 1/3 of the tongue. As simple as that. Now, another question arises. Tongue histologically is a muscle predominantly, and the muscle fibers on histology will be spread across various directions. The musculature of the tongue is derived from myotomes, the occipital myotomes, and the nerve supply is from the 12th cranial nerve, the hypoglossal nerve. So anterior 2/3 of the tongue, general sensation is lingual branch of mandibular nerve. The special sensory is chordae tympani of facial nerve, and the general as well as special sensory to the posterior 1/3 is glossopharyngeal nerve. The musculature of the tongue is supplied by hypoglossal nerve, the 12th cranial nerve, or the muscles of the tongue are supplied by the 12th cranial nerve. All different facts. You ask a patient to protrude his tongue out, and you see the tongue would be moving to the right, the tongue would be moving to the left. That is just as a result of the motor nerve, the hypoglossal nerve. And in case of paralysis of the hypoglossal nerve, the tongue would be deviated towards that side. You already know about that neurological examination. I would just like to pinpoint one other additional point over here. We have got this very important muscle, the genioglossus. The genioglossus is given the name as safety muscle of the tongue because in case of, say, conditions like seizures, epilepsies, the tongue can fall backward, and this genioglossus muscle, or in normal patients also, it helps in preventing the backward falling of the tongue. So you have to remember, genioglossus is the safety muscle of the tongue. And these are some of the important facts about the tongue. Now, can something go wrong with the development of the tongue? Definitely yes. We can have aberrations in the development of the tongue. Sometimes the tongue, there will be presence of only one lingual swelling. The other swelling will not be developed. Hemitongue, half of the tongue will be formed. Number one, although a rare defect. Number two, microglossia. This tongue would be smaller in size. And once this tongue would be smaller in size, we give it the name as microglossia. And microglossia would be classically seen in certain pediatric conditions like the Mobius syndrome or the cretinism. Cretins would have smaller tongues. Now, can we have large tongues? Yes. We can be having large tongues, which we give as the name macroglossia. So macroglossia is the presence of large tongues. And is it associated with something? Yes, it is very, very commonly associated with Down syndrome. In addition, we have this important clinical condition in our pathology, the amyloidosis, in which we have the deposition of the amyloid within our body. And there can be amyloid deposition in the tongue as well. And the tongue will be enlarged unusually. And that's macroglossia. Is there any other condition in which we can be having large tongue? Acromegalics. Acromegalics can have large tongue. Then we are already aware of, some DM students would be aware of, especially DM nephrology students would be aware of this pediatric condition, the Beckwith-Wiedemann syndrome. The Beckwith-Wiedemann syndrome has got this component of the presence of Wilms tumor, the presence of organomegaly, in addition to macroglossia, and sometimes classically hemihypertrophy of the body. But classic thing found in these patients can be macroglossia. So you have these subsets of patients who can be having large tongues or macroglossia. You have to remember one important clinical condition in which the tongue is anchored by a fibrous tissue towards the roof of the mouth or the floor of the mouth, which we give the name as ankyloglossia. So ankyloglossia superior or ankyloglossia inferior, which we also give the name as tied tongue. The tongue is tied and it makes it very difficult for the child to perform the activities from the tongue. And it is just done by having an incision to this fibrous band, and that would release the tongue. So microglossia, macroglossia, ankyloglossia, hemitongue will be some of the important embryological facts of the tongue. I hope I have given you an embryological basis of the innervation of the tongue, some of the important clinical conditions associated with this important part of the oral cavity, and I hope it will be very helpful to you. Thanks a lot.